Okay, we're going to go ahead and get started with the first session for today.
Yeah, I live like it. It's better than.
Okay, so the first session this morning is the Rehabilitation Continuum of Care, Hospital to Community Living. Again, I'm Denise Holt. I'm going to facilitate this session. I'll give a quick overview of the Rehabilitation Continuum of Care, and then each panelist will introduce herself and provide more details about the level of care and services within the rehabilitation stages. Before we begin, just to be official, I receive a salary from Kindred Healthcare in partnership with Missouri Rehabilitation Hospital in Springfield. Jennifer Braun receives a salary from Department of Health and Senior Services. Sarah Deal receives a salary from Missouri Vocational Rehabilitation. Debbie Dinzenbach receives a salary from the Center for Head Injury Services. Monica Hooten receives a salary from SSN Health Rehabilitation Network. And Cara Moore receives a salary from Vistal. All of these panelists have no relevant non-financial relationships to disclose. Okay, so once we get started, if time allows, we'll take questions at the conclusion of the panel presentation. I'm going to go ahead and get started. Is this my clicker?
Button.
Thank you. Okay, so in the beginning, when the survivor and the person served with the brain injury has their event, most likely they're going to end up in the emergency department, in the ED. So we have developed kind of an algorithm of the different paths that a brain injury survivor may have taken. So if you look first at the ED, you have the potential to go into the ICU, the intensive care unit, depending on the severity of your injury, and other things that may be involved in conjunction with the brain injury. Or instead of going to the intensive care unit, some hospitals, and I went off kind of the acute care network that I'm familiar with, you may go to the neuro floor. It may be called neuro intermediate. You may go to the step-down unit of the neuro unit as well. Then if you go from intensive care to the step-down, because you weren't quite ready just to go to the intermediate floor for neuro, eventually you're going to probably end up in that in the lower level of the neuro floor, okay? Then you can transition to multiple places once you're more stabilized from your brain injury. You may end up at an inpatient rehab facility. You may end up at a skilled nursing facility, or you may end up being able to go home. Again, this is relevant to the severity and the needs that you have when you have sustained the brain injury. So once you transition, let's go up to the inpatient rehab facility first. Once you complete that level of care, and the panelists will get more specific into these different areas and describe the level of services that are provided. You then, once you complete that care at the inpatient rehab facility, you may end up going to a skilled nursing facility, or you may be able to go home at that point. If you go home, then you may need home health care services, outpatient services that don't always just include therapy services. Sometimes when we say outpatient services, everyone just thinks that it's relevant to therapy. And there are some other channels to that as well, because you see voc rehab, you may have assistance from senior services. So there's a lot of different levels that can go into some of these different squares in this algorithm, okay? And that's what they will discuss. Same thing follows if you go home. immediately from your hospital admission at neuro, okay? I will say that sometimes patients, there could be another piece off of SNF, because oftentimes that may be a better level of care from a tolerance perspective than going straight to the inpatient rehabilitation facility, where there's certain requirements for therapy intensity that have to be met in order to be there, okay? That piece at the ED, and then the transition to one of those areas within the neuro floor would be where you would, at least what I'm familiar with, our liaisons are involved in an inpatient rehab facility. You have care management in the acute care facility that kind of helps facilitate that as well. Depending on what hospital you're at, they may have pre-built referrals in their orders that automatically pull the inpatient rehab facility in to start looking and making recommendations, okay? So I hope as they go through and explain the different levels of services, it'll help make more sense of the algorithm that's posted, okay? All right, so now we'll begin our panel discussion with inpatient rehabilitation, and this is going to be presented by Monica Hu.
Good morning.
Good morning.
I'm Monica Hooten. I'm a nurse with SSN Rehabilitation Hospitals. My role is to be a liaison to facilitate that smooth transfer of patients from the acute care hospital to the rehab hospital for additional therapies. So I'm going to talk to you today about our general requirements, what we do, barriers to admission, and then that criteria that's especially just for the brain injury patients, because it does differ a little bit. So inpatient rehab, what do we do? We're designed to provide intensive rehabilitation therapy in a resource hospital for patients who require complex nursing, medical, and therapy needs, where they can be expected to benefit from that interdisciplinary approach to care. So like I said, we're going to kind of go over the admission criteria, some challenges, and then specifically our brain injury patient population. So a clinical liaison, as was mentioned a little bit earlier, most rehabilitation hospitals have a person designed to work within the acute care hospitals with the case managers, social workers, physicians, nurses, to facilitate the most appropriate level of care for after discharge. Typically, we call them clinical liaisons because they're either a nurse or a therapist by degree. And we make the assessments based upon what the patient needs, our criteria, and the information that's provided to us from the hospital. We also educate patients and families and our referral partners about what we do and the programs we have, and most of all, ensure that safe transition from the hospital to our rehabilitation hospitals. In order to have any patient come to inpatient rehab, they have to have a qualifying diagnosis. Particularly, what we see most frequently are stroke patients, brain injury patients, spinal cord injury patients, amputations, any orthopedic conditions, patients that unfortunately underwent a traumatic event, and just kind of some other neurological disorders and other disease processes as well. The main portion that patients need to meet the criteria is to have medical necessity. And what I mean by that is because we're a hospital level of care, we have to justify why the patient needs to have the oversight 24/7 from physicians and nurses. So we're looking at their current condition and any comorbidity conditions that they also might have impeding their function. And at the end of the day, the ultimate decision maker for approval is our medical director. The patients also obviously have to have a change in function, right? Because that's why they're here, for more therapy. And granted, we know that everybody's baseline is a little bit different and it looks a little bit different. Whether you're independent, ambulating in the community without device, active, driving, working, or maybe not. Maybe you're wheelchair bound, the patient's wheelchair bound at baseline, but they could do for themselves. They could, help themselves get dressed, they could transfer themselves. So everybody's baseline looks a little different, but we're looking for that change, okay, a decline in the function. So with the decline in function and the need for therapy, they have to have 2 out of the 3 disciplines for therapy. PT, OT, speech, one of which has to at least be PT or OT. So we see any combination of OT speech, PT, OT, PT speech is, if you need that, you usually have all 3. The main thing also, and this is, we'll talk about in a minute, where the patients with brain injury, the patients need to be able to tolerate and participate the 3 hours of therapy a day. And sometimes that's where we can get hung up, and we'll talk about that again in a minute. And they also need to demonstrate the ability to learn. We're teaching them adaptations, we're teaching them how to move their bodies again and get dressed, and if they don't have that ability to receive the information and understand and process, it can be a bit of a challenge. We also really need to see that it's reasonable that the patient's going to make functional and or cognitive gains. We're a short stay, so we need to remember that these patients, they don't stay for a very long time, and in the short duration while they're with us, we need to make sure that they're going to make really good progress. We also look at, because they stay with us for a short time, where are they going to go after us? And like in the algorithm, there's many different options, but we just kind of want to get an idea or an estimate in our minds of what that might look like, so we can tailor their goals at rehab to where they're going to be after us, whether that is home, maybe a skilled nursing facility, or what have you. So we know the criteria, and what are we looking for specifically? What do you mean rehab diagnosis? So the liaison in the hospital is combing through the medical chart or the information that's provided to us from social workers and case managers. Has the medical workup been completed? Are there any outstanding tests? Is there a potential stroke patient but the MRI is not completed yet that confirms the stroke? We're looking at these things. What's going on where our doctor would need to see them every day? Is their blood pressure out of control? Are they at risk for pneumonia because they have dysphagia and might aspirate? Are they stable? Is there a downward trend in their blood counts? Or does it look like there might be an infection going on? Do they have a fever? We're looking at all those things. For discharge planning, what equipment do they have? Is this patient coming with a wound vac? Do they have a trach? Do they have a peg? What are we going to need in order to take care of this patient that might be special? So all of those are kind of things that we're considering. So with function, obviously, as I stated earlier, is there a change in their function? What was their baseline to begin with? What are they doing now? Are they tolerating it? Are they participating? Are they too tired and they just, the acute therapist comes in and like, I don't feel like it today. Well, if they're not going to participate or tolerate therapy in the hospital, 3 hours of therapy is not going to really be appropriate for them, possibly. And we like patients to be at least a minimum assist. What that means for non-therapists is that the patient is requiring at least 25% assistance from another person. So somebody has to be hands-on with them, assisting them in walking or feeding or dressing or bathing, toileting, what have you. So that's kind of what we're looking at. And obviously, will the patient improve? I'm going to skip over that one. So some challenges that we incur for general rehab populations is finding enough medical necessity or meeting their needs. Or, the acute care hospital is really focused on their length of stays now, and they want to get that patient out the door, but wait a minute, are they ready? There's a urine culture still pending, or they have a fever. So we're really kind of working with them as a team perspective to make sure we're doing the safe transition for those patients. These patients sometimes lack finances or support from family or friends, and sometimes that can be a barrier for us, because if they're not going to be able to go home or they don't have anybody to help them, placement might be an issue, or just meeting their needs in general might be an issue. Maybe they can't tolerate, or some patients, they have a short length of stay in the hospital, some have a longer length of stay, and things change with rehab, right? People get better, and the therapy continues while they're inpatient. Sometimes we're following a patient for a week or more, and they do great, and they end up being too good. They exceed our functional criteria, and they can go home. Or they can have a medical decline, and unfortunately get functionally worse, then might not be appropriate for rehab anymore. Insurance can be a barrier. Inpatient rehab is very comprehensive, and a lot of times it's not a covered benefit, especially patients that have Medicaid or no insurance at all. We do work with those patients to get what they need, and we have different resources to do that. But sometimes, we do require, or insurance requires us to get approval before we send patients to rehab. Sometimes that process can be a little lengthy. And the case managers or social workers at the hospital are like, okay, what are we waiting for? We're ready to discharge. We're waiting on insurance, because we want to make sure that the patient's getting what they need, even financially. We don't want them coming to rehab and then their insurance denies to stay and then they end up with a bill. So we're very cautious about that too, as well as being upfront with their co-pays. Some insurances require co-pays, and we want to make sure that they're going to be able to afford that. So with our brain injury patients specifically, we bring them under a traumatic event or non-traumatic event. Non-traumatic event could be maybe a hemorrhagic stroke or some type of encephalopathy, something of that nature, seizures, if the seizures really affect them. And with those patients, specifically for brain injury, we're trying to do seizure prevention, if they have central tachycardia or uncontrolled hypertension in those hemorrhagic stroke patients. We're managing their blood pressure. We're getting their pain under control. Maybe it's a traumatic event and they have also associated fractures. Then we're dealing with the pain too. Or they have a really devastating event where they require or required O2 through a trach. We don't take patients on vents, but we do take trach patients that maybe can have a little bit of oxygen go through here. And that's part of our goal. We're working with them to hopefully get them off of that and be able to talk and swallow again. And then, of course, wound care and prevention of any blood clots. So these patients, they obviously have a decrease in balance, strength, muscle tone, and it varies across the board, depending on the severity of the injury. Some are not ambulatory at all when we bring them to rehab. Others, they can do more for themselves. Maybe they're walking around fantastically, but it would be a very safe situation for them to go home because they think their toothbrush is a curling iron. So we're looking at that cognitive impairments as well. Especially neuropsychology. So when I say that inpatient rehab have is a multidisciplinary approach. Neuropsychology is very involved with our stroke and brain injury patients because they teach those coping mechanisms, behavior modifications, and help also deal with those labile emotions that can go with either of those injuries depending on where the impairment is on the brain. And because sometimes we can have a pretty functional brain injury patient, the ones that don't have any problems with mobility, they could be, sometimes that's a barrier to admission because they have to have 2 acute therapy needs. So if they don't have any PT needs, we have to try and justify the OT and speech portion of their deficits. So they could be walking all around, but like I said, just very not safe with their cognition. Then we have the opposite spectrum, where they have such a severe brain injury that they have a minimal conscious state. So those patients are not ambulatory. These are the ones that we see that have the trachs and the pegs that cannot speak. And we take them well because everybody has different goals, okay? And it's really based upon what type of injury did they have? Was it traumatic? Was it anoxic? The patients heal very differently. Where is that injury? Where is the brain injury? Because that's going to determine what impairments they have and their needs and their goals. And when did it occur? There are times where we get asked to assess patients that had a brain injury 3 months ago. And maybe they had gone through this continuum of care after the initial injury, but maybe they've shown improvement. And it took that long to kind of come out of their coma state or whatever. We consider those patients, we do. It is definitely case by case. But like I said, it depends on the type of injury that they had. Brain injury patients can require a lot of discharge needs. Some can go home, some cannot. And we have case managers that work with these patients and family to make sure they get the equipment and resources they need for after inpatient rehab. Thank you.
Okay, so another aspect in the continuum of care is connecting survivors and families with services of support, and early in the recovery process, the earlier the better. And this can be very beneficial to them as well, because everybody has input, everybody serves a different role in the recovery process, and so the next panelist represents a program where early referrals are recommended, and so now we'll hear from Jennifer.
I am, for those of you who don't know yet, I'm Jennifer Braun. I am fairly new to my position, about 9 months to a year-ish.
I can't hear you.
Oh, sorry. Is this better?
Yes.
Okay, so I'm Jennifer Braun. I am the brain injury manager for the Department of Health and Senior Services. I oversee the adult brain injury program. So today, that's kind of what we're going to talk about. The adult brain injury program serves participants between the ages of 21 to 65 who have sustained a traumatic brain injury. Through service coordination, the program links individuals to resources to enable each person to obtain those goals of independent living, community participation, and employment. I have 11 service coordinators that also help me with this program, and they're really the heart and soul of this program. I'm sure many of you guys have met them. If you guys just raise your hand or stand up or give a shout out. This program is not possible without them. They are fantastic at what they do. So if you have a chance, chat with each one of them. Okay. Individuals who meet financial eligibility requirements may also receive community-based rehabilitation services to help them achieve those identified goals. Rehabilitation services include counseling, both training, employment supports, and home and community-based support training. And we'll talk about those in a little bit. So to be eligible for this program, like I said before, you have to be between the ages of 21 to 65. You have to have medical eligibility guidelines. So we only serve participants that have sustained a traumatic brain injury. Those that have acquired brain injury, stroke, brain bleed, that type, we will not be able to serve with this program. We also require medical documentation of a traumatic brain injury. And this is probably the most difficult part of this job, did you guys say? That trying to obtain that medical documentation of a TBI. And then also, for those that are wanting rehabilitation services, you have to meet financial guidelines. So our financial guidelines within the state of Missouri are that you have to be at 185% or below the federal poverty level. That changes on a yearly basis. So for the year that we are currently in, for a family of 4, you cannot make more than $46,435. If you are over that, then you will not qualify for paid services. But you will still receive service coordination through our service coordinators. We do annual reviews. We call it annual financial eligibility reviews on every single participant receiving paid rehab services through our program. So there could be a moment in time that that participant receives services this year because they qualify financially, they get a job or wife gets a job, and then next year they don't qualify. So it's unfortunate. Service coordination. So what do our service coordinators do? They evaluate and assess the needs of every single participant. They work with providers such as Preferred, just for one. Develop a regular evaluation and update of a service plan, so determining what type of needs that participant needs. They assist in locating and assessing services and resources such as medical care, housing, vocational training, cognitive behavior training, etc. They also provide information, advocacy, and education to every one of our participants and families. Service coordination, like I said, is provided to all of our participants, no matter if they qualify financially or not. But if you do qualify financially, then you will receive rehabilitation services. Those rehabilitation services are neuropsych evaluation and consultation, adjustment counseling, transitional home and community supports, supported employment follow-along, and special instruction. We do have service limits that are lifetime service limits on the majority of these, and we can talk to you later about that because it gets kind of detailed out. But I will tell you, there's a little caveat for participants receiving paid services right now in the state of Missouri, because we don't have an unlimited budget, unfortunately. We do have a wait list. Our wait list is about 93 participants long right now. And their average wait time, I would say, is about 183 days, 184 days. So it's working on it. So whenever the service coordinators first receive an initial referral, we do a screener process. We have a screener form that we complete. This is just some of the questions that are on that screener form to try to begin those initial conversations. So question 1, have you ever hit your head, been hit on the head, or had an item penetrate your head and as a result experienced a loss of consciousness or a period of feeling dazed and confused? Second, have you ever been seen or in the emergency room, hospital, or by a doctor because of an injury to your head? And do you experience any of these problems in your daily life because of the injury to your head? So headaches, dizziness, anxiety, depression, difficulty performing your job, school, work, etc. So if they answer yes to probably 1, 2 of these, we are definitely going to be going out and doing an assessment. We do what's called a service coordination assessment on every single one of our participants. That assessment is about 19 pages long. It's insane, but very thorough. Our overall goal for this program is that our participants are able to manage their self-care needs. So they're able to be independent, be able to go out into the community, take care of themselves, pay their bills, do the organization that they need to, manage their household needs and personal affairs, that they're able to go out into the community and do social activities, and that they complete those educational services, so like for the supported employment or the special instructions. If we have an individual that needs assistance obtaining their driver's license or getting their GED, this program will assist those participants in doing that. And then we also want them to complete vocational rehab services as well. That's all I got. I'm pretty short and sweet.
All right, thank you so much, Jennifer. Okay, so just keeping in mind that transition to support services early in the continuum of care is important. And also referring survivors and family members to the Brain Injury Association of Missouri so they can have that support in the early stages as well. And really at any stage, just confirming that they have that contact information for outreach services, just for the support and education. So Debbie will now take us through the next level of the rehab continuum.
Good morning. My name is Debbie Dinstock. I'm an occupational therapist, and I work at the Center for Head Injury Services. I'm going to be talking today about our day program, and as well as our outpatient program. So the Center for Head Injury Services, a little history, has been around for quite a long time. It was actually started probably back in the 80s. It was a program called the Academy, and it has had several titles over the years, and has been the Center for Head Injury Services now probably for the last 20 or so. All right, I have to put on my glasses, sorry. All right, so our day program, it's a friendly, stimulating, safe environment where individuals with brain injuries and other related disabilities can socialize, improve on their skills, and enhance the quality of their life. So we are available 5 days a week, Monday through Friday, for full or half days, 9 to 3. And then we do offer some care before, after, if necessary. And then goals are based on the participants' medical, physical, behavioral, and cognitive abilities, as well as their interests and personal preferences. So really anyone who has a diagnosis of brain injury, and it doesn't have to be a traumatic brain injury. So we have several participants who have developmental disabilities qualify for our program. We have several individuals who have your traditional diagnosis of a TBI, some individuals who have diagnoses of CDA, encephalopathy, et cetera, et cetera. We offer a variety of activities. We do offer occupational therapy, physical therapy, and speech therapy services to our day program participants if they qualify. Not everybody qualifies, and that is determined based, unfortunately, on their funding source. So there are some consumers in our program that we think probably would benefit from some therapy services. And those individuals, if their insurance or their funder source will not pay for it, they have chosen to pay for it privately. So we do have a few consumers that receive therapy in that respect. Our goals for therapy, and I won't speak just exclusively about therapy, but our goals for therapy primarily are for maintenance. Many of our clients, our consumers, are either they've had this injury since birth, or if it is an acquired injury, some of our consumers are 10 to 20 to 30 years post-injury. So a lot of the things that we're working on are more social participation and what we call higher level life skill activities. So the other things that our day program offers, we do have staff there We have a staffing ratio, and we have staff that offer different programs throughout the day, different activities. So cognitive activities, we have daily living skills building, we have cooking club, we do a lot of out trips where some of our consumers who are able to, they go out and volunteer at different job sites. We have group counseling, we have individual program goals that we set for every single consumer. So it's based on what they want to achieve from their program, what their caregivers want, and so they're tailored and they're very individualized. We do offer nursing care daily, and that is for medication management primarily. We do, on occasion, have some, we'll have a history of somebody, if they have a history of seizures, and the nurse will have to intervene if that person is active with their seizures. Offer social skills training, community outings, and then, as I said earlier, opportunities for therapy. We do also offer rehab counseling, individual one-on-one counseling too. So we also will work on pre-vocational skills building. Our organization, the Center for Head Injury Services, offers many, many programs. The day program and the outpatient therapy program are just two of our programs. But if you go and look at our exhibit booth, we also have a representative here from employment, vocational. We also have 2 social enterprises. And so there's a lot of really great things. We also offer a program for adults with autism. So all these different activities or programs that we offer here. We are starting now working more closely with a behaviorist for behavior programming. That is sort of new to the outpatient, to the day program. It is somewhat in its infancy. All right, and so admission criteria. So documented brain injury or related disability. So again, when we're saying brain injury, we're not thinking that the traditional traumatic brain injury. Any type of a brain injury will qualify. They must be 18 years or older, and obviously no limitations that would preclude their opportunity to participate. So that doesn't mean everybody has to be ambulatory. We have a lot of persons who are limited to a wheelchair, but as long as they can participate and engage, then they are obviously welcome to attend. Let's see here. Sorry, I have lost my eyesight. Obviously, they have to have a minimal elopement risk, and what we mean by that is because we have more or less an open door policy, we have a very large facility. We don't want to have our consumers deciding that they want to go outside unsupervised, because we are concerned that somebody may decide to go for a long extended walk, and we don't know that. So usually we have scheduled break times, we do have outdoor activities, but persons are usually supervised during those time periods so that we know where everyone is. All right, and the payment source. So we're funded through the Department of Mental Health, through Developmental Disabilities, and Department of Health and Senior Services, or private pay. Presently, we don't take private insurance. We are currently working on that as far as beginning to accept private insurance, as well as Medicare. So those are the three ways that you can receive payment. So for outpatient services, I should also have in here counseling, but we have OT, PT, speech therapy services, as well as counseling. And the criteria is very similar to the day program criteria. Again, we currently are offering private pay, and we do have some consumers who do offer to pay privately. We do receive a lot of calls for persons who have insurance and or Medicare, and so we have begun that process in working towards being able to see those consumers as well. Our outpatient therapy program, some of our consumers have been coming to us for 4, 5, 6 years. Some of them are there more for an acute visit, so we may have seen some folks for just maybe 6 weeks to maybe 12 weeks because they just come from an inpatient setting. But many of our consumers see us for a longer period of time. I know one of the consumers that I see, I've been there a little over 3 years, and the consumer that I see has been coming to the center for over 12 years. So a wide variety of times for rehab. Ooh, mine's very short, sorry. Any questions? The Center for Head Injury Services, we're on Lackland in the Westport area. It's in St. Louis, yes, Maryland Heights area.
We're on schedule. Does anyone else have another question currently? Go ahead.
Actually, when we're talking about admission standards to a IRF, you talked about speech, OT, PT. You didn't say whether or not cognitive therapy could be an admission standard in treatment, and why or why not? This is a highly effective thing for recovering from traumatic brain injury.
Yeah, that falls into the consideration of speech when we're looking in the acute setting, like the acute hospital. So speech will touch on both dysphagia and cognitive declines as well.
And that's in conjunction with that, occupational therapy can also address cognition as well. So, additionally, OT and speech will often, depending on the needs of the patient, attack that together because the cognition plays such a role, maybe in the physicality of things as well, the sequencing of steps and different things to be able to get transferred from your chair to your bed into the shower, different levels. And so that's a really good question. But usually speech is the primary, and OT kind of helps pick up the slack a little bit, or depending on if it's more of a physical need, OT may really address some of that cognitive aspect as well. And some patients really don't care for speech therapy, and so sometimes you have to allow the occupational therapist to address that. I can speak to that because I'm a speech language pathologist, so that's not uncommon.
This might be getting a little bit too far into the weeds because I'm going to talk about acquired brain injury, and has insurance gotten any better about covering the cognitive therapies for people with acquired brain injuries in terms of strokes? Because I know 8 years ago they didn't.
So you're asking if insurance is any better at allowing cognitive therapies for acquired brain injuries, strokes
Strokes of some type.
Okay.
That may be too far into the weeds, but I know that was.
Why don't we go ahead and continue, and we'll come back to that question at the end, because that may take a little bit, more time, and I don't want to get too far off.
That's fine.
Schedule here. So raise your hand again at the conclusion, and if not, just reach out to one of us when we're finished. Okay. So thank you, Debbie, for your information. Appreciate that. And so now we're going to move on to the next portion of the rehab continuum, and Kara is going to come up and discuss independent living as the goal for each survivor of brain injury.
Okay, can you hear me okay?
Yeah.
Great. All right, my name is Kara Moore, and I am the Brain Injury Services Program Assistant for the Brain Injury Foundation of St. Louis. I am pursuing my MSW at Washington University, but most importantly, I am a stroke survivor 22 years post-injury. Today I'm here to talk about the transition from inpatient to in-home services. So, via online research and word of mouth, individuals reach out to organizations to inquire about the services that are available to them. But because eligibility for most services is not directly determined by the organization itself, they are referred to the state agencies where eligibility is determined, and they are matched with the best, or with an organization that best meets their transitional needs. At the Brain Injury Foundation of St. Louis, it is our mission to provide innovative, community-based solutions to meet the specific social and vocational needs of individuals with brain injuries. The scope of services, oh, you know what? I'm sorry, I'm forgetting. The scope of services provided by BISFL fall under two main programs: the Department of Health and Senior Services Adult Brain Injury Program and Vocational Rehabilitation. Under DHSS, clients can receive Transitional Home and Community Support, also known as THCS, pre-vocational training, and long-term follow-along. Oh, no, I almost forgot. Through vocational rehabilitation, clients will also receive job development services. Right. So, as the Brain Injury Services Program Assistant, I assume many roles that include direct care worker, group facilitator, volunteer coordinator, and I'm also a pre-vocational instructor. As I assume these roles, clients will see me as their trainer and coach, so it is important for me to build relationships based on empathy and trust. So while I'm very encouraging with them, I oftentimes have to challenge the thought processes that are keeping them from moving forward in life. So sometimes people ask me, what do clients look like? What's the client profile of clients before they actually receive services? So from what I've noticed, clients will typically lack an understanding of brain injury and how it's actually affected them. They will be typically mostly dependent on their natural support, so that's like their family and friends. They don't really like doing things for themselves at this point. They feel a sense of loss and isolation, and they will typically lack a sense of purpose. Okay, so first I'm going to talk about the Transitional Home and Community Support Program. All right, so through THCS, goals are client-driven to focus on the things that are most important to them and can include things like organizational skills, budgeting, interpersonal communication skills, meal planning and prep, community outings, and public transportation training. In the pre-vocational training program, clients learn the soft skills needed to obtain and retain employment. These skills include appropriate communication in the workplace, the importance of enthusiasm and attitude when looking for a job and keeping a job, and working in teams as well. Additionally, clients will participate in a multi-phase mock interview, which includes interview scripting. And clients will also practice all the skills that they've been learning at multiple volunteer sites. And that's also very important because it gives them a place to practice to build their physical and cognitive stamina as well. So once clients are going through services and maybe they're nearing completion, they will typically have gained a better understanding of the effects of sustaining a brain injury. What I really like to see is they have a new renewed sense of self and normalcy, because what I see in my work oftentimes, they get stuck trying to recover the life that they once had, and that's not going to happen. So what I have to do is I have to help them kind of build a new life. And I think about, well, instead of trying to recover your old life, why don't we build something that's even better than what you had before? And let's see. So within, and clients will have also learned the use of assistive technology and compensatory strategies to optimize their level of independence within their homes and communities. Within the THCS program, clients are allotted 4,000 lifetime units, which is equivalent to 1,000 hours. So once a client maximizes their level of independence, services will typically be discontinued. And we do that because we aren't exactly sure whether or not they might need to use those services again in the future, so we don't want to use them all at once if we don't have to. Now, for clients that have completed the program, they will typically focus on job development through vocational rehabilitation, although it's actually common for clients to participate in both programs simultaneously. And if you're wondering what we do with those clients who aren't eligible for DHSS services, which is unfortunately is 1/3 of the brain injury population, they will just go ahead and start VR services right away. And that's all I've got.
Great information, thank you. So now we'll transition to the next portion of the rehab continuum, and that employment has many benefits for the individual with brain injury, community involvement, purpose, self-sufficiency, and so we're going to have Sarah come up and share the important aspects of this in the rehab continuum.
So, as I said, my name is Sarah, and I work for vocational rehabilitation.
Could you hold the microphone closer?
Yeah. First, I got to figure out how to navigate this thing. Okay, so some of the things that we'll talk about today is just what is vocational rehabilitation. That's not necessary. We'll talk about what is vocational rehabilitation, how does someone become eligible for VR, what services does VR offer, brain injury specific services, and how to begin working with VR. So for the purpose of this presentation, when we talk about brain injury, that includes both traumatic and non-traumatic. And just out of curiosity, by a show of hands, I know I see a lot of really familiar faces, which is great. Is there anybody in here that's not familiar with voc rehab or never heard about it before? All right, this makes my job really easy. Okay, so essentially, in a nutshell, vocational rehabilitation is a state agency that focuses on assisting individuals with a disability obtain, maintain, or advance in their employment. So when we talk about eligibility for services, there's 3 different pieces of information that we look at. One is their documentation of a disability, documentation of a physical or mental impairment. It's not my favorite verbiage, so it's not typically what I present to clients, but that's the official terminology that we use. Does that impairment cause difficulty in obtaining and maintaining employment? And is there a service that VR provides that somebody can benefit from? So I'm going to actually reach out to some of the other vocational rehabilitation counselors in the room and ask them, what does that mean for a client to be able to benefit? If no one's to volunteer. Sorry, I like to move around. Standing in front of people just makes me more nervous. All right, Vicki, can you explain that for us?
Basically, is it an impediment to their employment?
Yeah. So sometimes folks come to us, and maybe it's a little too soon after their injury. Maybe stamina endurance is concerned. Maybe they need to do some additional therapy to really work on some of those cognitive skills. So we want to make sure that competitive employment is a good fit for that person at that time. So services available through VR, these are services that are provided to any client that's eligible for VR services, provided to counseling, career exploration, assistance in increasing job seeking skills, job development / job placement, job coaching, or job support. So job coaching is typically done on-site, a little bit more intensive, versus off-site might just be over generally checking in, making sure things are going well for the client on the job. Some services that are based on financial needs that are available through Voc Rehab are funding for vocational training or tuition and assistive technology. I would also include rehab technology, not on this slide. So with vocational training or tuition, it's essentially us working with the client and talking about, okay, if you pursue this kind of training, what is the likelihood that you would obtain a job in your field? So if you live in St. Louis and you're interested in being a marine biologist, but you're not really willing to relocate, you might have some struggles getting a job, right, in that field. So services specific to brain injury. So we have a program that we call Employment Services Plus. We think of it as a very holistic and collaborative approach to VR services that creates a continuum of care in assisting individuals to transition from either rehab to employment, or maybe from high school to employment, if it's an individual who's acquired a brain injury while they were a young child, right? You hit the wrong button. There we go. Okay. So with Employment Services Plus, we're typically going to go one of two ways. So if somebody was working when they acquired their injury, then we might look at returning to work if that's appropriate. If it's not possible or the client isn't wanting to return to that job, then we're going to be looking for new employment. So as you can see, we've got a nice little kind of chart demonstrating how services come about. The first step is always that initial intake, which is this red box right here. So where we're gathering a lot of information, we're working with the client, working with their support system, their therapist, kind of trying to get an idea of possible vocational goals. We might talk with the client about if they are interested or they feel like they would benefit from additional services, then we might look at different provider options that would also be involved in the process. Once we kind of have a game plan of what services we're looking at, what supports are going to be helpful, then we go about developing what we call our individual plan for employment. This outlines the kind of the job goals that they're wanting to look for and what services they're going to receive to help them reach that goal. Then, ideally, right, then we get to employment. So once a client obtains employment, Voc Rehab follows this case for at least the first 90 days, which is really helpful, right? We don't ever want to just help that client get that job and then say, okay, bye, peace out, good luck. So we like to follow along, make sure things are going well. Some individuals do have the benefit of funding outside of Voc Rehab for what we call long-term retention, which Kara mentioned earlier. Okay, so as far as providers for this particular program. So most of you are probably familiar and even work for those agencies, but here's the list just in case. Okay. So what is the benefit? So what do you guys think would be the benefit for somebody to have a program that's specialized to brain injury?
Can you say that again?
What do you think is the benefit of having a specialized program, employment program, for somebody who has a brain injury?
More individualized planning and caring.
Absolutely, yeah. So what we find is that individuals with brain injuries, their limitations might be similar to other types of disabilities, but the root cause is very different, very unique. So having somebody that understands those specific limitations is really crucial. And we find that it's very beneficial in having successful outcomes.
Still true that a person with a brain injury could have the part-time position or the full-time.
So that is all up to the client and what seems most appropriate. So if they have the stamina and endurance for full-time, if they want to pursue full-time, then absolutely, then that's what we would support them in. If they're wanting to look for part-time, kind of slowly re-enter the workforce, then that's what we would support them in. So it's driven by the client. Okay.
Can I say this to my address or I think the majority of people for full-time employees, so that's
It really just depends.
yeah, it's individualized, totally with the best of the client, but I've never heard that before, that they have.
So how to get involved. So a lot of individuals are referred to those rehab by professionals, by case managers, therapists, doctors, but they certainly don't have to be. So clients can be referred from a family member, they can call themselves and sign up at one of the local care offices. So we have about 26 offices across the state of Missouri. And so to find the location that serves your area, you just go onto our website. Like I said before, all services start with that initial process of an intake appointment. So a couple of things that are required for that is just some paperwork, right? We are a state agency, you can't get away from paperwork. And then documentation of a disability. So just kind of an FYI for anybody who's interested in referring individuals, some helpful information to have. Therapy notes, insight regarding the client's potential career interests. And if you're looking at return to work, obviously information about their prior job and sort of where they're at functionally. And that's all I have. Thank you so much. So hopefully the presentations that each individual has provided kind of helps give some insight to the ifs, ands, and buts of the rehab continuum of care. It's always important, of course, like we've noted, to introduce the support services that are available, not only on a state level, but on a community level, depending on your location, and just working together through the referrals to connect the patients and their families to the various support services that are available along the continuum of care is going to help us all better serve their needs and help them be more successful in returning to more normalcy. So I want to thank everyone on the panel. And at this point, if you do have any questions, and with regard to your question on insurance and benefits, do we have any care managers in here? Don't be shy. From an IRF? Okay. So
I have somebody who wants to talk to me. I work with both commercial and government payers, and I'd be happy to tell her kind of what I see currently.
Okay, so if you want to tell her about some trends, what I can tell you just from working with the care managers from an IRF perspective is that plans change all the time, it appears. Reviewing your benefits, having a family member review the benefits to know what you do have. Just historically, I think from a speech-language pathology standpoint, if cognition can't be addressed on that level given your benefit plan, then going the route of occupational therapy to go ahead and address those needs. And so anyhow, that's really about as far as I would go into that because I'm not a specialist in insurance, and I always tell my therapy team, do not speak to benefits.
One of the things is that how acquired brain injuries, at that time anyway, were treated differently than traumatic brain injuries. And so you get shoved over to the category, this is stroke, and then anything where somebody gets conked on the head becomes, and how insurance covered that was different.
I could say generally, commercial payers, how their brain was injured is not necessarily an issue. Many social service or government programs are based on how they were injured, but commercial payers don't look at that. It's a brain injury is a brain injury.
As an occupational therapist, and I still work rehab also, really a lot of it just depends upon if the patient's making progress. And if they continue to make progress and your insurance pays for it, they'll continue to reimburse. It's when you stop making progress is when it becomes dicey.
And I'll just add on the inpatient rehab side of it, that there are still insurance companies that don't consider speech cognition as a qualifying therapy. There are still some handfuls that they like to just have PT and OT in order to qualify for those two acute therapy needs. So there are some out there.
They're all very specific. So if you have anyone that you know that's a case manager or a care manager in a facility that I would say is located near you and you have questions, I could just reach out and call the department, call the main number of even a hospital or an outpatient or an inpatient rehab facility and just, ask some general questions. They should be able to assist you even if you aren't a patient there. Maybe their director of care management could provide you some assistance with your questions. In the back.
Actually, within the Bureau of Special Health Care Needs, we have a program called the Children and Youth with Special Health Care Needs program, and it serves children with a traumatic brain injury from birth to age 21. So we have a lot of participants that transfer from that program to the adult brain injury program.
On that same note, do their units get used up if they're in the children's program and then they transfer to the adult program?
No, we're two separate programs, two separate units. With the children's program, there is a cap limit, so they can use up to $25,000 per year per participant, and then our program starts them over brand new. It's two different types of services. So like within the children's program, they can get that OT, PT. We help pay for specialized medical equipment, those types of things, and then us, they could get maybe THCS.
Any other questions? I think this is just a great overview, so thank you all. And we have a gift for each of you from the Brain Injury Association. So there you are. Okay, so we'll take a 15-minute break now. There should be coffee and refreshments over in the exhibit hall. Remember to get your raffle tickets. At 10:30, we'll resume with neurological testing in this room. So enjoy your break. We'll see you in 15 minutes.
Yes.